evidence. And if there's any questions during my lecture, please feel free to ask anytime and any question. This is for basic endoscopic principles and handling, and most of the slides are from Professor Kim, and that's why I noted both of our names. This slide highlights the contrast between an ideal and a less than ideal setup for a surgical procedure. As a beginner, you might face some challenges like in different anesthesiologists, nurses in training, or older devices. But however, the goal is to work towards an ideal situation with a cooperative and skilled team and a perfect surgical equipment. So when I was I started my practice since 2018. And when I was a beginner, all the environment in surgical field in our operation room was very new to me. But I'm not the expert compared with the Professor Kim, but as I set up our operating room that is suitable for me, it is getting much closer and much familiar to me. This slide outlines a detailed surgical procedure, particularly for the removal of pituitary adenoma. It mentions using various instruments like a dissector, ring cuvette, and forceps to remove the tumor. This slide, as Professor Kim showed this slide yesterday, most of knowledge is from Professor Kim. And the procedure and also includes the steps for irrigation, managing CSF liquid, and packing the nasal cavity with materials like nasopore tampons at the end of the operation. And this is our table of contents for the presentation. We will cover these three main topics: the operating room setup, manipulation techniques, and the specific instruments used in endoscopic surgery. And maybe there is many and famous centers all around the world. This slide shows various operating room setups from different locations, including this is the Thomas Jefferson Pittsburgh, Thomas Jefferson USA. This is operator and assist and the scrum nurse. So to make the room for the endoscopic surgery is dependent on the preference of the neurosurgeon, the surgical hand in the room. So to know every setup all around the world, especially for the famous facilities, is very helpful for you. And this is the facility in the Napoli, Italy. And you see the operator is here and scrum nurse is here. And this is France. This is operator, assist, and scrum nurse. And maybe if someone has some experience in handling the surgical instrument, you may feel at first time very uncomfortable because the hand of the assistant and the hand of the operator has some fighting. So how to deal with these instruments also important. I will mention about it later in this slide. And this is the surgical field in Pittsburgh. In Pittsburgh, the doctor neurosurgical operation sits here on the right side of the patient hand, and the assistant sits the left side of the neurosurgeon. In Pittsburgh, each doctor holds the endoscope for the neurosurgeon, and the scrum nurse sits the right side of the neurosurgeon. So, as Professor Kim told yesterday, this is the linear alignment, but it feels a little awkward or a little some difficult for hand over some instrument from scrum nurse. So in the real field in the Seoul National University, we have modified some other setups. And this is the surgical setup for the Seoul National University from Professor Kim when he was in early period. In that time, it's like the Pittsburgh in linear setups. But nobody showed their, but in the middle of the period, the Professor Kim changed their setups because in the linear setup, they have to show their back and the back side so they can make some contamination. And in this, the face-to-face alignment, scrum nurse can pick up and take over the diagnosis to the right-hand surgeons. Most of the neurosurgeons are right-handed, so the scrum nurse and neurosurgeon said face-to-face, it is much easier than the linear alignment. And and this is the surgical preparation, surgical operating room preparation at Seoul National University Hospital. And this is the Bundang Hospital, my operating room. At first, we have the face-to-face alignment. But actually, for me, I changed the surgical operating field in the linear alignment because our anesthesiology team says some difficulty to manage the air circuit because when the surgical anesthesiologist sit the foot side, the air circuit was very long and it makes some very large dead space for the ventilation. So we changed a lot. So the surgical setup is the team alignment. So you should talk with your assistant, the scrum nurse, and anesthesiologist, and that makes the operating room. And now we move on to the core manipulation techniques. This section focuses on how to handle the instruments effectively during the surgery. To perform the surgery effectively, the devices must allow for fine and free movement of hands. This means securing enough space for your hands and ensuring the cables of the endoscopic and camera are cleared away and don't get in the way. So if the line of the light source, the camera is disturbing the surgeon's hand, it is very difficult to handle. So always keep away from the cables from the surgeon's hand. That's why the assistance is important. And this slide introduces a key concept, avoiding the fighting between the endoscopic and the surgical instrument. A crucial tip is to change the grip of suction device and do not touch the endoscopy with your hand. Maybe most of the neurosurgeons are familiar with the hold their suction tip like this way because we are familiar with the microscope. But if you hold this surgical suction tip like this, it is very it will be very unfamiliar and very difficult to hold the endoscope. So please, if you are willing to do the endoscope surgery, it is better to change the holding of how to hold the suction tips. And this image shows a product that was not successful. It is a device from Asus. Why did it fail? It had a small orifice for surgical device, which restricted the use of microsurgical instrument, and the location of the camera and cable restricted the hand movement. So always keep some space between the surgical hand and the field. There is a good surgical kit. And this is a visual example of the manipulation technique in practice, showing how the surgical hands and the instrument work together. Always make some space between the endoscope and the surgical hand, and that's how to insert the bipolar. That's how to use the bipolar tips, and so we have many surgical clips, so you can have many experience through these lectures. And let's take a look at the specific instrument used in this type of surgery. Many of the neurosurgeons and many of the neurosurgeons are not familiar with this kind of instrument because ENT doctors may know very much about this endoscopy silent surgery surgical instrument, but neurosurgeons do not do the endoscopic approach usually. So get familiar with this kind of instrument, micro instrument is very um, the first step of this technique. So this slide provides a detailed breakdown of the various instruments in the transsphenoid approach. They is set up at Seoul National University Hospital. They show the different types of micro instruments, including punches, suction tips, scissors, forceps, and more. This set is essential for performing precise endoscopic surgery. So I can mention all these kind of instruments now, but there are some important things. First, we should use the Carrington punch that is very small, like 1 millimeters. We do not use the 2 or 3 millimeters. And as you see the surgical instrument tips, it is 40 degree forward, and you should use the curved and straight suction tips like Fukushima fascia. That's why we to because we have to insert the Fukushima suction tip through the long side of the nether base. And this slide shows the difference between the microscope and the endoscopic view. For the microscope, all the instrument is centered in the surgical field. But if you put all the instrument in the center of when you are doing the endoscopic surgery, you make some fighting with the endoscope and instrument. So always keep some space in the center of the endoscopic view. And this video clip shows how to manage the surgical view through endoscope. Always some space in the center, and the instrument will be located in the outside this kind of endoscopic view. So to make some space in the center of the surgical endoscopic view makes can prevent some fighting with the instrument. And is how to use the punching. And as the Professor Kim told yesterday neurosurgeon demonstration, when the carbonous sinus or the blue line is show up in the film, don't twist the punch. You make some discenter like the venous bleeding, and that's how to handle the this case is the meningioma, and that's how to handle the instrument like this. Some space, always keep the space in the center of the endoscopic view. It's a dissect from the superior hypophageal artery, and always keep the some surgical field space. And to avoid the fighting between the endoscopic and device, as I mentioned before, a curved tip of suction device is needed because the fighting of straight suction with endoscope in the same corridor. So bayonet type surgical device is microscopic surgery when the microscopic instrument is installed and move the suction horizontally, not the vertically. So if you move the suction vertically, usually makes some fighting. So always move the suction tip the horizontal way. And it shows some difference between the bayonet type of the surgical instrument. So, and we have also upward and downward suction. And this is the microneedle holder. And this is the gun type bipolar forceps. I saw this type of bipolar forceps in your operating room yesterday. And we also need micro bipolar forceps, and micro instrument, and micro scissors, dissectors, and micro forceps, and some kind of irrigation. And this slide is the explanation of all these surgical instruments one by one to educate my scrub nurse. So the instrument, some instruments maybe are not available in Indonesia, and some are available. So it is not always essential or the mandatory, but I will share this slide with you, so you can get used with this instrument. This is the usual TSSA when I begin my endoscopic surgery in 2018. And so this is all the base, and some are we have some modifications now. But at first, when you do the endoscopic surgery, maybe you need all these kind of instrument. And this is the suction tip set, mallet, and J-Cream. So you should, you are not always to use this old instrument, but sometimes when you're doing the extended endoscopic surgery, maybe you will use these all kinds of the set and micro set. So at first, when you're studying the endoscopic surgery, you should get used to this old micro set. This is the micro set for rotating straight scissors over the left and right scissors. So it will be very useful for your resident and nurses to educate with this slide. And this is the debrider. And the camera is dependent on the equipment company. And this is the bipolar. We are using Sutter bipolar. And this is the drill of the Midas drill. The suction body, and T-type bipolar, and extended bipolar, and etc. So I cannot mention all of these. And when I use the tacos, we cut the tacos in this fashion. For the surgery of the yesterday case, we do not use the tacos because there was no CSF leakage. But when the bleeding poke, like the intercarbonal sinus, and the carbonal sinus is very difficult to handle, we can use the Flowsil or the Tacosil. So maybe I heard that the Tacosil is not available in Indonesia yet, but maybe in the future you will get used to this kind of Tacosil, because the Flowsil, the Tacosil is very useful to handle the venous bleeding. And the navigation stand, and okay. For the endoscopic surgery, while incredibly useful, endoscopic surgery has some technical limitations. The optic control is not automated, requiring manual zooming and focusing. You must also contend with issues like fogging, blurring, like in this video, and contamination. So it is involved features of the endoscopic surgery, so you should get used and get familiar with this kind of some limitations. And another limitation is the lack of an automated holder for the endoscope, meaning an assistant who holds the endoscope must manually hold it through the procedure. So that's the one kind of limitation. For the microscope surgery, a surgeon can move the microscope by the footstep, but in the endoscope surgery we cannot. There's one kind of limitation. And perhaps the biggest limitation is the lack of true 3D view, while the view on the screen is 2D, two dimension. A scaled assistant dynamic movement of the endoscope helps the surgeon gain a sense of depth. So that's why one of the importance of the assistant, if the assistant feel free and rotate the endoscope, the surgeon can feel the 3D view. So there is some tip for clear surgical view. To overcome some of these challenges, it's important to know a few tips. First, you should secure the surgical corridor by gently pushing the mucosa with the suction. And secondly, you can avoid the bloody surgical field by using pledges to prevent mucosa. So when I first started my endoscopy course, I cut the syringe tips and practiced to hold insert the endoscope through the very small size of syringe. By practicing that, I can move I can get used with the endoscopic manipulation, and by putting the syringe, the endoscope through the syringe tip, there was no vibration, like tremor. So practice makes perfect. So at first you should get some practice. Like this. There's some other kind of tips for endoscopic surgery for clear surgical field. As I mentioned before, always mucosa oozing is the major source of the bleeding surgical field. So avoid to touch the mucosa when you manipulate the endoscope, and use pledget and coagulate and drill or resectate the bone and the mucosa. The mucosa is remaining the spinous sinus. It remains the bleeding, and avoid the unnecessary detachment of mucosa from the skull base. So mucosa can sometimes can make profuse bleeding, and some bone bleeding can gently prevent it by waxing. And that's all for the surgical tips for endoscope. And if you have any questions from this lecture, feel free to ask me anything, because we are in short of time. And any questions?
Here.
And because in the morning we have the two lectures. One is the surgical tips and the preparation for the endoscopic surgery, and other part is endoscopic Indonesia transsphenoidal and transplantal approach. And let's begin with a review of the skull base. It can be divided into three main areas. The anterior skull base is related to the nose and the orbit, with the ethmoid complex as the major midline structure. The middle area is related to the infratemporal fossa and pharynx, where the spinal bone is the major midline structure. Finally, the posterior skull base is related to the posterior fossa, with the temporal bone being the key structure on each side. When we consider surgical approaches, the skull base is divided into central and lateral compartment. This division is made by an imaginary sagittal plate that connects the medial pterygoid and the third occipital condyle. The line between these 2 points is also where the carotid artery enters the skull base. And this slide shows a closer look at the middle skull base, specifically the stellar and the parastellar area. You can see the stellar optic nerves and the internal carotid artery. This is the area we will be focused on for the transplant approach. on the right, we have a sagittal diagram of the paranasal sinuses showing the key structure like the frontal and sphenoid sinuses, the turbinates, and the ethmoid builder. The endoscope is entered like this through the sphenoid sinus, sphenoid rostrum. And this next section of the presentation will cover the key nasal structures and the use of nasal septal flap. The nasal septum is a critical structure. It has both cartilaginous and bony component. The bone component includes the rectangular plate of the ethmoid, the vomer, and the parts of the frontal and nasal and maxillary palatine bones. So this diagram also shows the key dimensions, such as we should keep the 1 centimeters, 1.5 centimeters length of perpendicular plate when cut the bone, because if you cut the most of the bone perpendicular plate, if you do not remain some kind of bones, then you make some saddle nodes. So that is very important to make some endoscopic endodental approach. And this endoscopic view shows the olfactory strip, olfactory epithelium, which is a key area to be aware. We can identify the olfactory strip, and you can see the fine yellow axial vascular pattern like this, running parallel to the fiber. So always keep the olfactory strip to secure the olfaction. Here we see a diagram of the blood supply to the nasal cavity. Key arteries include the anterior and posterior ethmoid arteries, the sphenoid palatine arteries, and the greater palatine arteries. Understanding this vascular anatomy is crucial for minimizing the bleeding during the procedure. This is an endoscopic view of the nasopharynx. Key landmarks include the fossa of the rosebular fossa and torus tabulus and Eustachian tube in the pharynx. And this slide highlights the two important structures, the uncinate process and the hiatus of semilunaris. The uncinate process is part of the ethmoid bone, and the hiatus semilunaris is a crescent-like shaped groove located below the ethmoid bulla. So always keep this kind of the surgical imaging is important. And these CT images show the different parasurgical plane we use for surgical planning. We can see key landmarks from the frontal sinus, cribriform plate, and the sphenoid sinus. We can see the ethmoid artery. Sorry. So always keep the before doing the surgery, always keep the CT first and keep the imaginary location of the anatomical landmarks is very important. So it's not obvious, but you may imagine the anterior and posterior ethmoid artery. Where the anterior and posterior ethmoid artery is, the anterior ethmoid artery is usually located from the 2.2 or 2.5 centimeters from the frontal sinus, and from the anterior ethmoid artery, the posterior ethmoid artery is located about 1.5 centimeters. And these diagrams illustrate the drug-free approach. Drug approach may be very familiar with the ED doctors. So the relationship between the key arteries and sinuses. Anterior ethmoid artery is running from the backside, and some crossing from lateral to the anteriorly, like this, not straight, some kind of from the lateral to the medially, and the posterior ethmoid artery located horizontally. So this how to identify and distinguish the anterior artery from the posterior ethmoid artery. And this endoscopic image is a greater way to review the key anatomy of the nasal cavity. You can see the superior and middle and inferior concha as well as the nasal septum and the guana. And the vomer is located in this, and sphenoid ostium is at the inferior third of the superior concha. Maybe the mostly sphenoid ostium is located 1.5 centimeters from guana. And before the surgery, it is necessary to perform detailed CT scan of the osteomeatal unit CT. This allows us to evaluate the size of the nasal cavity and identify any septal deviations and pinpoint of the location of the ostium, and we also use this to understand the pneumatization of the sphenoid sinuses, including its relationship with the internal carotid and optic canal. This CT image shows the various surgical routes for the transsphenoid approach. The routes are identified by their relationship to the inferior and the middle turbinate, as well as the inferior insertion of the superior turbinate. So you can, as you reviewing the OMU CT, you can imagine and estimate where the inferior, middle, and superior concha is located. So always keep the deviation and anatomical landmarks before the surgery. And the sphenoid ostium is a reliable and crucial landmark for navigation during this procedure. You can see the ostium here. And this image shows the nasal route leading to the sphenoid ostium. So to widening the space between the middle concha and the septum is important. So always soaking the mucosa with the epinephrine gauze to keep it longer. The mucosa will get atrophy very well. So that's why, and that's how we can make those space between the middle concha and the septum. And the endoscopic approach to the sella has several advantages. This is the way, one kind of the approach that is called posterior septectomy. It is a quick and require no manipulation of the anterior mucosa. However, it also has disadvantages such as the need of the posterior septectomy, potential mucosal bleeding, so in a narrow nasal cavity. So by only remove the posterior septectomy, we can approach the sphenoid sinus as quickly. Professor Kim, I always use the bilateral surgical approach. It's an alternative way to enter the sphenoid sinus between the posterior septectomy. Its advantage includes the preservation of the all nasal structures and ability to overcome septal deviation. Disadvantages, however, is difficult with lateral extension and the need for posterior ethmoidectomy. So you can cut the cartilage from the bony structure. You see this kind of video clip yesterday. So always keep the left. This is the left side nostril. Always keep the cottonoid on the left side before cut some body tips on the right nostril. So by making some small incision on the right septum, you can keep the bleeding. You can prevent the bleeding from that comes from the upper side of the nose. And this slide simply highlights the location of the septal incision. So where we put the septal incision on the right side of the nostril is very important to prevent some mucosal bleeding. So we set the septal incision in the inferior part of the mid-concha like this, not that too deep inside. So that's how to prevent the mucosal bleeding from the upper side of the nose. And the approach to the sphenoid sinus depends on its degree of investigation. We use the traditional classification with 4 types, the conchar and precellar and 2 types of the cellar. And so by reviewing the OMCT, you can guess how the imagination of the patient is. And these images show 2 key steps of the endoscopic transsphenoid approach. This is the posterior septictomy, and this is the bilateral sphenoidotomy. This allows for clear access to the sphenoid sinus. You can choose any kind as needed. So by opening this, final view is like this. And after the endonasal nasal phase, you can enter the sphenoid sinus. So you can see many anatomical books that is all drilled out the sphenoid septum. So always get used to the skull base anatomy and get reminded of the skull base imaging is very important. And your job is to drill all the septums to make the surgical field very clean. So in the skull base surgery, you may get used to this, the weird optic tuberosis. This is the middle OCR, lateral OCR, and after you should remove all these intersinus septum to expose the cellar area. This is how to after the drilling out all the interspinous septum. This is the cellar exposure. And after removing the cellar floor by drilling out, you should make the cellar floor bone like the eggshell type. So after making the eggshell type, the cellar floor bone can be removed very easily like this. So that's how we prepare for the main procedure. And after removing the cellar floor, you can get the final view in every case on the right side of the column. And after I will not mention the main procedure, but after the procedure, we perform multi-layer reconstruction of the skull base. The base is to use the multiple layers of tissue to seal the dural defect. This often includes the primary dural repair during materials like fascia or fat for reinforcement, and a bony layer or rigid construction like this step. And there are many kind of ways of the skull base repair. First, the most important thing is to prepare the pedicle nasosectal flap, and maybe you can use bilayer button technique. There is some kind of sealing called doubling technique, and some gasket seal technique, and 3F technique. And but when the bone is very intact, we usually use the paste graft and hydrosalpetide and nasosectal flap. So it depends on the surgeon's preference and where the bone is intact or not. The pedicle nasosectal flap is a vital tool for skull base reconstruction. We can use technique like bilayer button or gasket seal, often in conjunction with the fat and other sealant. So this flap is designed to be longer and wider than the defect to ensure the proper scale. So this AP diameter can be fit to the exposure of the skull base, and this the vertical diameter is fit with the dimension of the skull base defect. And this diagram illustrates how the nasal septal flap receives its blood supply from the posterior septal artery. And we also see different branching pattern of the artery to the sphenoid ostium, like this. And this is a critical anatomical detail for successful elimination. Here, we can see the specific incision line for the nasal septal flap. The monopolar culture is used carefully to make the incision. Mostly the incision is made from inferior and anterior and superior, and lastly the posterior. So to get familiar with this kind of approach and to make the preserved nasal septal flap is very essential to prevent the CSF leak. During the dissection, we must be careful to avoid the septal perforation. The goal is to create a superior margin below the insertion of the middle turbinate, and we can also consider contralateral nasal septal flap or a unilateral reverse flap, which is useful for wide surgical cavities. Like this is one example of the reverse flap. Other options for skull base reconstruction include a temporal parietal fascia flap or a gallia flap. So I will skip this. And this is the unilateral or bilateral pedicle nasal septal flap. It depends on the width of the skull base defect. So bilateral flaps in the skull base defect is when the more than 2/3 of the clevis is exposed, you should better prepare for the bilateral pedicle nasal septal flap. Like this. That's how we can prepare the bilateral nasal septal flap and to expose the clevis. Like this after the surgery. You can put the bilateral nasal septal flap covering the most of the clevis. So the other things is the pedicle. Beside the pedicle nasal septal flap, the inferior or middle turbinate flap or transpterygoid transposition of temporal parietal fascia flap or gallia flap and glacialis lateral flap can be used. It depends on how the surgical defect is exposed and where the nasal septal flap can be used or not. And this is how we can get to the transtuberculum or transplanum approach. For the transstellar approach, the cella is very enlarged and the overall distance of the superior intercavernous sinus and diaphragm can be identified, and we should widen the surgical window. But for the transtuberculum approach, is above the superior intercavernous sinus and diaphragm through chiasmatic system under aortic nerve, so it can keep the surgical window very narrow. We should do the sphenotomy first to enter the transtuberculum. It requires the superior border to secure the surgical view for the posterior plantar sphenoidally. In pituitary macroadenoma with cellular enlargement, to obligate the chiasmatic circus by the cellular enlargement. So targeting the limbus sphenoidally is very important to expose the transplanoid approach. this is the steps of the procedure for the transtuberculum and transplanum approach. Is first, most of the cases can be there will be a CSF liquid. We better prepare the pedicle nasal plate at the nasal base. Then wide sphenoid and posterior ethmoid sinus exposure is important. And bony removal of sella floor, tuberculum sella, and posterior sphenoid is very important. And due to opening and dissection followed by tumor debulking and tumor dissection from optic chiasm and nerves, infundibulum, and surrounding arteries is very, very important. And finally, the reconstruction to prevent the CSF leakage. And this is the positioning. Head elevation above the heart and slightly tilted toward the right side of the face to face the surgeon is very important to expose and to put the instrument very easily. And for the tuberculum sella meningioma, sphenoid sinus and the depth of sella is the anatomical key. So, pneumosinus dilatans can be identified in Doimi CT. After bilateral anterior and posterior estomidectomy and wide bilateral sphenoidotomies, the visualization sella protuberance defines the center of the skull base. And next, the intrasphenoid sinus septa are trimmed and facilitating the identification of the transsphenoid sinus anatomy and bony bursts. So you should remove the above the sella, above the superior intercavernous, and how to drill and how to start the drilling first is dependent on the surgeon's preference, but always keep not to injure the optic nerves or optic protuberance or optic carotid protuberance is very important. And durotomy initiates in the upper part of the sella below the superior intercavernous sinus, and next the tuberculum dura is inside, and the CSF and the superior intercavernous sinus can be coagulated and transected or pushed down. This is the key landmark to approach the transtuberculum approach. Key landmark is the posterior ethmoid arteries and optic nerves and both ICA and optic chiasm, and superior hypophyseal arteries and anterior communicating artery. You can expose and you can guess where the anterior communicating artery is before the surgery started through the CT or the MRIs. And this is the surgical approach to the tuberculum sella, especially for tuberculum sella meningiomas. This table shows the result of the retrospective multicenter studies. So, analyzing and comparing the endoscopic endodontal approach and the transcranial approach for tuberculum sella meningiomas, the study found that the visual outcome were significantly better with the endoscopic approach. So, but that means that the endoscopic surgery is much better, but it depends on the how the tumor is extended and how, the preference of the surgeon. And this is the surgical clip for the tuberculum sella meningioma. For tuberculum sella meningioma, the goal is to devascularization and resection of the tumor with careful decompression of the optic canal. And it is important to protect the superior hypophyseal artery after drilling out these all the bony structures. You can do the duotomy like this, and always keep for the tuberculum sella meningioma cases, always keep the arachnoid plane. You can always get the anatomy of the arachidoid plane. So if you keep the arachidoid plane, you can easily dissect the tumor from the optic nerves and the anterior community arteries. So that's how we prevent how to not injure some very important neurovascular structures around the tumor. So by doing that, you can easily dissect the tumor from the neurovascular important structures. Yes, like this, you can dissect tumor from extracapsular dissection, like this. So this is the final view of our surgical clip. And so this is because of the time limitation, we skip some surgical clips, but it is how we decide how to make which approach can be selected. If the slide from Professor Kim, if the patient has some visual disturbance, but if the patient do not have the visual disturbance, we always keep regular follow. How it is not dependent on the size of the tumor, and if the optic canal invasion is not identified, the decision how to do the transcranial or transpenal is patient preference maybe. If the dural attachment is impacted recurrence, we should use the transcranial and transpenal approach both. But if the dural attachment is not intact, we can choose the transpenal approach. So the most benefit tumor from endoscopic skull-base surgery is ideal vector of surgical approach to resect of the tumor and present the preservation of the dural structure and vasculature, like this. And I can, because of time limitation, I skip these surgical clips, and this is the end of the slide. And if you have any questions, feel free to ask me. No? Thank you.
Alright, thank you, Professor. Next up, we're going to have coffee break and some snacks at the anatomical lab at consumption room. Thank you. Please follow the committee from behind.